Thank you, Dr. D'Souza, Dr. Vachrajani, and the organization committee for inviting me here to do this talk. Even though I came in monsoon season and I'm jet lagged, I can see how beautiful and lush Goa is, and it gives me a very beautiful impression of India. And thank you very much for your hospitality. So I've been charged by Dr. D'Souza to talk about endovascular AVF fistula creation, but I want to start off by telling you that the gold standard for hemodialysis vascular access is the arteriovenous fistula. And this was described in 1966 by Brescia, Semino, Appel, and Hurwicz when they described the connection between an artery and a vein using surgical stitches, as you see here. And with that, we have the development of the arteriovenous fistula that has now become the gold standard because of its low complication rates and long patency. However, this was described 50 years ago, and since then, our patient population has changed. They've got greater comorbidity, elderly population, and living longer on dialysis. And with that, we have now seen a change in the complications with arteriovenous fistulas, with the primary failure rate of 20 to 60% in some reported cases in North America. A mean maturation time as high as 4 to 9 months. An average use time of the fistula, not 5 to 12 weeks, but 5 to 12 months. And the average number of interventions to facilitate and use a fistula to be 2 to 3 per fistula, with the thrombosis rate varying between 5 to 25%. So that's a lot of complications and a lot of cost to not only the healthcare system, but to patients. So what do patients think about this? And when you ask them in a very standardized, formal manner, they actually have what we call surgical fatigue. These are some of the comments that patients have actually said to me. Don't fillet my arm anymore. I don't want any more appointments, no more pre-admission visits. I don't want any more surgeries. So they're, really afraid of their fistulas failing. And the guidelines also tell us, as Dr. Vachrajani said, really we need to preserve vascular access real estate, going from a distal to proximal approach. And for everybody, we say, it's been 50 years now, let's have some more innovation for this fistula. So how can we make everybody happy to fulfill their needs? So we now have our current access options. As you know, we have our fistula, we have our graft, and we have our catheter. Is there something else out there? And really what we need to do is we need to think outside of the box to be able to create a fistula that's going to be able to be the gold standard, but to perhaps have a limitation in the complications. And so, like a vision, maybe like a natural miracle, somebody thought of something. And this person here is Dr. Billy Cohen. He is a cardiovascular surgeon and really brilliant. And what I'm going to tell you is actually a true story. He is a cardiovascular surgeon and working in the emergency room one night in Boston. And in comes a man who had this event. He had a fight with his wife. So I suggest you don't do this at home. So he had a very angry wife, and what the wife did was she picked up a kitchen knife and she stabbed him in the leg, okay? And so he looked at this knife with, in this patient's leg, took it out, it was a clean cut, and all he did was just suture up the lesion and sent the patient home. And as serendipity has it, again, he was on call in the emergency room about 4 to 5 months later, and the same man came in. And the surgeon said, "You had another fight with your wife?" But what happened was he felt a throbbing in his leg. And what happened was when that wife put the knife in the leg, she actually made an incision between the artery and the vein, and when the surgeon took it out, he created an accidental fistula. And this has been reported in the literature with penetrating injuries, with gunshot wounds, and you can see that a fistula has been created in this leg. And so what Dr. Cohen thought was, how can we make a fistula without stitches? Because clearly we can do this. And so he had this really brilliant idea. He likes to do lots of inventions and play around in his workshop in his garage, and he really likes using magnets. So what he came up with was this device, which is now called the TVA everlinQ endoAVF system. There are 2 catheters. This is a venous catheter lined with rare earth magnets. And in the middle of the venous catheter, you can see this radiofrequency electrode. This is an arterial catheter. In the middle of the catheter is a ceramic backstop. So what happens is you put the venous artery in the vein, the arterial artery the arterial catheter in the artery, and the magnets attract each other so that in the middle, the radiofrequency electrode and the ceramic backstop align. This is connected up to a radiofrequency generator. So then what happens is you press a button which then deploys this radiofrequency electrode. It gives about 2 seconds of radiofrequency energy, creates a channel between the artery and a vein, and a fistula is created. So my question is then, if you try to do this with this brilliant idea and you try to create a radiocephalic fistula, would it work? Okay? So you probably think this is a trick question because I'm up here, so of course it must work. But actually when we tried it in the radiocephalic, to create a radiocephalic fistula, it didn't work. And the reason why it didn't work is because there's too much tissue between the artery and the vein, and so the magnets could not attract. But this was really a great idea, and we didn't give up. So what we did was we actually had 20 human cadaveric arms, and we used this thing called PMMA, which is bone cement. And we put red dye for the arteries, put that bone cement in the arteries, mixed blue dye with the veins with PMMA and put it in the veins so that the cement hardened. And once it hardened, we actually dissolved the flesh with this sodium hydroxide. And we came up with these arm models. And what we wanted to do was we wanted to find vessels that were close enough so that the magnets could align. And after a lot of searching, a lot of different models, we actually did come up with an area. And what we found was that if you see the ulnar artery and the ulnar vein, they're pretty much in approximation. So we could actually create an arteriovenous fistula here. And the important aspect of this is that there is a perforating vein that takes you from the deep system to the superficial cephalic vein, median cubital vein, and basilic vein, and from this a fistula could develop. So this sounds like that we have the anatomy, and with that we were able to also identify some cannulation areas. So it was a very good concept. And I'm going to show you a cartoon of how it is going to work. So just remember that the system consists of 2 catheters that have magnets and a radiofrequency generator. And remember that it's the ulnar artery and vein that we're targeting. So in order to get there, we actually have to have brachial access. So this video is going to go by a little bit quickly. So what's going to happen is that we're going to have an arterial and venous puncture at the brachial vessels with a guide wire placed, and then the catheters will be inserted. Whoops. Okay. So here we have the guide wire placed into the vein as well as into the artery. Over this, we're going to insert the arterial as well as the venous everlinQ catheters. Once the catheters are both placed, you will see that the magnets will interact and align. Once they attract and go together, the radiofrequency electrode is deployed. It is then given radiofrequency energy to create a channel between the artery and the vein. It is then removed so that there's nothing left in the system. Blood will directly be flowing, creating that fistula. And then afterwards, depending on how many brachial veins the patient has, we'll coil embolize a brachial vein to help divert the flow from the deep to the superficial system to create this fistula, and we have multiple cannulation sites. So that is the cartoon of the procedure. And should it work, then it has many potential advantages. Consistent hemodynamic anastomosis, no vessel trauma, torque or tension, may have clinical improvements with low failure rates, few interventions, low complication rates, and the bottom line is we want to improve delivery of care to our patients. That was a cartoon. Does it really work in real life? So I'm going to show you a video of the procedure in a human. And the one thing I want you to notice is that this hand is actually down on a handboard, and why might this be? The first time we ever did this was a patient in Paraguay, and remember where that fistula is that we're actually creating, it's in the elbow, and when you give radiofrequency energy, what's going to happen is your hand's going to jerk up. So the first time we did it, that arm jerked up and hit the operator in the head. So now what we do is we hold it down to prevent this happening. So now we have the patient having his arm prepped. Whoop. This is fine. Can you make it run? Thank you. So the arm is being prepped. We're going to do a central venogram to make sure there's no central venous stenosis. The most difficult aspect is actually getting the brachial vessel access. It's something that most interventionalists do not do. The arterial guide wire is already in, and I just wanted to show you that sometimes it is a bit difficult to pass the venous guide wire because you're actually going against the valves. So once you have the arterial and venous guide wires in, we're going to repeat the venogram to make sure that we have the vessels in the right place. This is the arterial catheter. It's going to be placed over the guide wire. Then we're going to pass the venous catheter with the radiofrequency electrode, as you see here. And it will be passed next to the arterial catheter. The magnets will start to interact. You can see the radiofrequency electrode there, and we're trying to find the right position. It's very critical that the right position is made. You'll use your C-arm to make sure that you're in the right position. When you have the right position, you'll see no space between the catheters. Right about here, the radiofrequency electrode is now in the right position. It's going to give 2 seconds of energy. A fistula has been created beautifully without any extravasation. You can see that there's been charring, that it has been properly deployed when you take it out of the patient's body. Again, there's coil embolization of a brachial vein if the patient has greater than 2 veins, and a final angiogram shows that there is no extravasation. So we've now created an arterial venous fistula. People always like to see the electrode being deployed here. 2 seconds is all it takes, and the fistula has been created. If there's any nurses in the audience, you can see this is what the fistula looks like 24 hours after the procedure. Really beautiful fistula. So the pilot study was done in Paraguay. It was called the FLEX study. It was a single-center prospective study of 33 patients with 6 months follow-up. The study endpoints was technical success, patency, and safety. You can see here, however, that the patients in Paraguay are quite different from the North American population. Significantly younger age, 51 years old. Only 30% had a BMI greater than 25. Only 6% were pre-dialysis, and only 12% had previous fistulas. However, 58% of them had diabetes. The results were very impressive. 97% technical success, 96% patency at 6 months, and 96% of them were usable for dialysis. The average time to maturation was 58 days, with only 0.15 interventions per patient year, 4% thrombosis, and only 1 person had a serious device-related adverse event. So very, very impressive results. This has been published in the Journal of Vascular, JVIR, in 2015, and that was the pilot study. So to conclude this part of the presentation, the fistula remains the gold standard for vascular access. It's imperfect and lacking in innovation. However, the endofistula is a promising innovation for fistula creation using this magnet-line catheters that deliver radiofrequency energy. And the proof of principle, or the pilot study, was done in the FLEX study. Now, the key question is it applicable in today's technology in North America in both our pre-dialysis and dialysis patients who need a vascular access?